We are starting vestibular schwannoma today after having spent considerable amount of time on CP angle anatomy and then retrosigmoid approach. So this is going to be relatively boring because obviously it has a lot of theory and it's not surgical. So brace yourself, it's going to be boring, but it is a really, really important topic, both in terms of patient management and in terms of exam. So then let's begin. We will do the clinical presentation today along with the science and one of the classifications. We will do the investigation segment tomorrow because that is going to be really, really heavy. And on the day after tomorrow, we are going to have a decision-making session in terms of discussing different scenarios, patients with NF2, patients without NF2, different sizes of tumors. We are going to discuss different scenarios, cases as in, so that it gives a very comprehensive understanding of how to decide the management plan. So the primary clinical presentation for vestibular schwannoma is obviously going to start with cranial nerve 8 deficits. This is a tumor that arises from the 8th nerve. Which component? Vestibular, right? I am audible.
Yes.
Okay. So
Yes, ma'am,
this
you're
arises.
audible.
Okay, this arises from the vestibular component and especially the inferior division. Sometimes this is asked. This is a trivia you should remember. It arises from the inferior division and it arises from the vestibular nerve. The primary deficit is going to be vestibulocochlear. Patient will have sensory neural hearing loss deficit. And this is usually, if the patient is presenting early in the course, this might be the only symptom they have. Sometimes, if the tumor has gotten big enough, the patient has presented to you late, they will have a combination of other symptoms. Usually, this is the first symptom you're going to see, and it might present in isolation. Roughly 5 to 10%, the literature varies in terms of the frequency here. 5 to 10% patients present with sudden sensory neural hearing loss as well. Can somebody mention why? Why sudden hearing loss? Anybody? There's ischemia of the cochlear component. If that is the case, then let me write. If that is the case, then the patient is going to present to you with sudden sensory neural hearing loss, as opposed to the chronic progressive presentation that we usually see in the patients. Another important thing to remember, which we will come to discuss later on, is this poor speech discrimination. Patient will have a relatively better PTA, pure tone audiometry. When we do it and when we discuss it, we will find that the speech discrimination is very, very poor in these patients. And this is a hallmark that something is going on around the CP angle. We will have a separate, I think, discussion over PTA because it is a sore subject in terms of residency. Let me get back. Yes. Apart from the sensorineural hearing loss, patient is always, not always, but almost always going to have the component of tinnitus. They will present to you telling you that their ear has these noises and they cannot sleep due to it. They often cannot focus due to it. So tinnitus is a big source of disruption of their normal daily life, especially prayers. Apart from that, they will also complain of vestibular dysfunction, but vestibular dysfunction can be of both origins. It can be due to the vestibulocochlear nerve involvement. It can also be due to the cerebellar involvement if the lesion is big enough. Let's look at the sequence. Why is this sequence important? Does anybody remember the anatomy of CP angle? How did the facial nerve and everything else look like? I'm going to draw. This was facial nerve, right? And on top of it was our vestibulocochlear nerve. Part of the facial nerve was hidden behind it. And slightly superior to it, we had the trigeminal nerve, right? And now we are saying that this is a lesion of the eighth nerve, vestibular component. So technically, what should happen? Which is the first nerve that is going to get involved after eighth nerve?
The facial nerve.
Yes, it looks like the facial nerve would get involved early, but that is not the case when you look at the clinical presentations. Oftentimes, the involvement of trigeminal nerve is it presents earlier than the facial nerve involvement. Why is that? Can somebody mention?
Because the facial nerve motor fibers are more resilient to damage as compared to the sensory fibers of the fifth nerve, I think.
That's brilliant, Dr. Sana. You're right. The motor fibers are more resilient to compression and to ischemic necrosis in comparison with the sensory component of the trigeminal nerve. So as soon as the tumor grows out of the internal auditory canal and inside the CPA cistern, the first thing that they affect is this, the trigeminal nerve and the sensory component of the trigeminal nerve. So cranial nerve 5 involvement is going to be chronologically early in comparison with cranial nerve 7 involvement. 7 is usually involved in a much later stage. Change the color. So let's look at the sequence of cranial nerve involvement again. And you can see that the eighth nerve is involved first. There's hearing loss, there's tinnitus, there's unsteadiness. Afterwards, we have the cranial nerve 5 compression. And the most sensitive test of trigeminal nerve involvement is what? The diminished corneal reflex. Patient will have diminished corneal reflex, and that is why if you miss doing corneal reflex during cranial nerve 5 examination, it is counted such severely, because this is oftentimes when rest of the components of the trigeminal nerve are intact. Like there are no paresthesias on the face, the temporalis and the masseter, all of it is intact. Even then, corneal reflex can be diminished. Also, look at the word. We are not looking for an absent corneal reflex. Even if it is diminished in comparison with the normal side, it still gets counted as cranial 5 involvement. Apart from that, you can have mid-phase paresthesias, which is when V2 and V3 get involved. Corneal reflex is carried by V1. So obviously this is going to present first. V2, V3 is going to come later on. Once the tumor has started filling up the CPA, only then you usually get the facial nerve involvement. And patient can have hyposthesia, patient can have motor paresis, could be visible depending on the House Breckman grading. Apart from that, is anybody aware of this sign, Hitzelberger or Hitzelberger sign?
Yes, this is the loss of sensation in the posterior inferior ear canal.
Okay,
Early sign.
so this is posterior superior. This is the
Okay.
only correction I want to make. Otherwise, you are right, Dr. Sana. So what happens is when the facial nerve is involved in a CPA tumor, the posterior superior portion of our internal auditory canal, it ends up losing the sensation. Usually, even if you're not looking at any obvious facial disfigurement, any asymmetry, Hitzelberger sign can still be found because, like corneal reflex, it is an early feature in comparison with the overt motor paresis that you're going to see. So, what happens later on if this keeps on going? What's the next stage?
Brainstem compression and lower cranial nerves involvement.
That's right. So this is the possibly the worst case scenario when the patient presents to you with pre-existing lower cranial nerve involvement with pre-existing brainstem compression. Since there is brainstem compression, there can be long tract signs as well. Patient can have obstructive hydrocephalus. If this patient has obstructive hydrocephalus, what else is going to be there in terms of signs? Papilledema, right? So depending on the stage of, or if I put it in this way, depending on the size of the tumor at which the patient has presented, your presentation is going to vary a lot. Sometimes you are going to get the patients who have nothing going on apart from hearing loss, and then you will have to figure out what is the cause of hearing loss. Sometimes you will find some diminished corneal reflex or hyposthesia over the midface. Overt facial nerve involvement and overt brainstem compression, lower cranial nerves, they are usually going to present in patients who come from very outreach areas and who do not have access to neurosurgical services very early on in the disease process. Let's move on. Okay, so we did cover this part. The origin is cranial nerve 8. And we know what is the mechanism of involvement. The mechanism is going to be stretch and ischemia of the nerve fibers. Even at times, if you see an intact nerve and you're trying to separate the tumor capsule, a lot of times there is no use of saving these nerve fibers because they have already gotten ischemic and the fibers, they are not functioning anymore. Then we have cranial nerve 5. The trigeminal nerve, we already discussed it. I do have some images, but they are far ahead. And we did discuss that it compresses the sensory root of cranial nerve 5 superiorly. And yes, we already discussed that since the sensory nerves, the sensory portion is more sensitive, it gets involved early on. Even though we see the involvement of trigeminal nerve, patients do not have trigeminal neuralgia-like presentation. Please give me a minute. I have an interruption. Apart from that, we did discuss that facial nerve fibers, since they are motor fibers, they are particularly resistant to the mechanical compression. So they are sacrificed pretty late in the course of the disease. We are not going to cover the house Breckman breeding today, since I figured it would become a very, very boring lecture. Rest of the signs would include Hitzelberger sign. Let me see if I have a picture here. So when I say posterior superior, this is what I mean. So this is the portion which is going to get anesthetized while the patient has compression in the CPA. It's a very sensitive sign in terms of diagnosing a lesion. Why is that? Because the posterior superior external auditory canal is supplied by the sensory branch of the facial nerve. Patient can have altered taste perception, but usually this is subjective. I have not found a patient in my clinical practice who would complain of, altered taste perception. Usually they are worried about other things, but this can be one of the presenting complaints. Apart from that, we have late stage mass effect. We already discussed it as well. Patient can have brainstem compression. If there's involvement of brainstem, patient can have long tract findings as well. Cerebellar compression can be there. So ataxia and nystagmus is something we want to watch out for. These are the most important thing in terms of prognosis, because if they are already involved, the patient would need to be counseled regarding the PEG tube and the tracheostomy, which could be likely if there is involvement of lower cranial nerves already. You need to watch for dysphagia. You need to watch for hoarseness. and you need to watch for diminished gag reflex. Sometimes, even before we actually examine the patient, the way they talk, their voice, and their complaint that we are getting recurrent cough gives us this warning that there might be lower cranial nerve involvement. Apart from that, you can have hydrocephalus and all the manifestations that come with raised ICP and hydro itself. So, since we have done CPA anatomy, I'm not going back there. Let me see. Who is in the chat box? It's not downbeat nystagmus, Dr. Shahid. Downbeat nystagmus is very typical for Chiari malformation or CVJ pathologies. It is a horizontal nystagmus if that is what you want to ask. Let me draw here. You can see this yellow thing outlined. This is the internal auditory canal. You can see the facial nerve going on. You can also see the eighth nerve going around. If you also remember the anatomy classes, there would be an intrameatal loop of ICA as well. The tumor begins inside the internal auditory canal, right? It begins here and then it starts to grow. So this portion, let me clear this up. This portion here, once the internal auditory canal ends, this is the cisternal component. This is the CP angle cistern region. Once the metal component ends, the tumor moves in there. Why am I specifying this? Because there are classifications that will be, placing the tumor according to the space it is occupying. This is the metal component or the internal auditory canal component. Once the canal it gets over and it moves in this CP angle cistern, then this is the cisternal component. It might be big enough to cause compression over the brainstem. You can look at here. It is displacing the brainstem towards the other side. This is a coronal view, by the way. I'm sorry, I forgot to mention. This is another illustration. Are we all on the same page or am I going too quick?
It's clear.
Okay. So let's look at some CPA ankle anatomy again. And if you focus, I'm sorry, I cannot zoom it. If you focus at image D, you can see how beautifully it illustrates all the relationships that are important and that we have already discussed during the CP anatomy. You can see the tumor, right? Behind the tumor, what is this? Which nerve
Facial
is
nerve.
this? This is facial nerve. It's hiding behind the tumors. This is the back view, and that is why it's drawn in a lighter way. Apart from that, what else can you see? There's something really interesting. You can see the trigeminal nerve on the superior portion. Do you all remember the uh, anatomical relations of the tumor with the CP angle structures? Or do you want me to
Yes,
include it
ma'am.
in the next session? So facial nerve goes anterior, right? So in the retrosigmoid approach, you are not going to find it on the superficial surface because you are looking at the posterior surface. We have discussed this thoroughly. Superiorly, you are going to find the trigeminal nerve and the other favorite, superior petrosal vein. Apart from that, what else do you see here?
Aika.
That's right. And
And basal cranial nerve.
so can somebody mention the relationship ICA has here? It's visible in the image, by the way. It's going posterior, if you see. You cannot see it once you open it. And when we were discussing ICA, we also made a point to remember that it can have anatomical variations. You can find a single trunk. You can find two trunks. You can find an early labyrinthine artery branch. So there are multiple anatomical variations of ICA. Apart from that, what else is there? Did somebody say pica or I misheard it? This is pica here, very small, right at the inferior edge of the tumor. And if we expose even below, then you are going to look at the lower cranial nerves. Ideally, it's not a good exposure. Your exposure should be limited to this portion, the superior and the middle neurovascular bundle. The best way to preserve lower cranial nerves, in my very limited surgical experience, is to not expose them unnecessarily, because nerves are very sensitive to traction, even if there is no obvious or overt sign of injury. Let's look at, can you see what is happening here? Where my cursor is? What is happening here?
Madam, the tumor is inside the vestibulocochlear nerve and it's expanding the nerve.
Yes, but what is this place exactly?
Intracanalicular canal.
Yes, this is the lesion here. We can use both terminologies. This is going inside the internal auditory canal. If we look at it from a surgeon's perspective, if we look at it from an anatomist perspective, then this tumor is coming out of the internal auditory canal. So it depends how you choose to frame it. This is a beautiful image of both the CP angle cistern and a dissected view of internal auditory canal. I was not sure if I included it in the original presentation, but you can see that ICA is making this loop here. This is the intrameatal loop. Apart from that, you can see the facial nerve and the vestibulocochlear nerve. So once we are done with some really beautiful surgical anatomy, we are back to boring science. Eighth cranial nerve signs are really, really important because this is your primarily involved cranial nerve. You want to localize, the first thing that you want to localize is the type of hearing loss, whether it is conductive or it is sensorineural hearing loss. How do we know it is sensorineural hearing loss? The Weber is going to lateralize towards the normal ear, right? And ear conduction is going to be more than bone conduction. This confirms that this patient has sensorineural hearing loss. Apart from that, there's going to be speech discrimination deficit. And this is something we will discuss tomorrow, inshallah, why low STS and high PTA, they are so classic for CPA tumor involvement. Apart from that, somebody did ask about the type of nystagmus. Downbeat nystagmus is usually a characteristic of CVJ lesions or more, Chiari, BI, stuff that is happening at CVJ. You would not see downbeat nystagmus in vestibular schwannoma. The kind of nystagmus you see is when you ask the patient to look towards the side of lesion, there's going to be the slow phase. And when you ask him to look away from the side of lesion, there's going to be the fast phase. If you want to categorize the nystagmus, it's very difficult to manifest in the patients, but good to remember for exam. Fast phase is going to be directed away from the lesion. The slow phase is going to be directed towards the lesion. We come back to the diminished corneal reflex. We have already discussed it. Apart from that, facial hyposthesia starts from V1, can progress to V2, V3, depressed corneal sensation. Then we come to facial nerve. You can find Heidelberger sign if there is no overt paresis. If there is overt paresis, then you will need to grade them according to House and Breckman grading. And if you get an EMG done, there would be an abnormal blink reflex or abnormal facial nerve EMG. We already know the cerebellar signs. There is nothing new here, nothing complicated. Patient will have a positive Romberg. Patient can have tandem gait ataxia. Dysmetria, dysdiadochokinesia is going to be there if there is cerebellar compression. And there is going to be Bruns nystagmus. We just discussed it. Apart from that, we're grading. Let's come back to this image. So can you identify the vestibular schwannoma in the first image? Image A.
Madam,
you
there
give
is
me-
a small portion in the internal auditory canal on left side.
That's right. It's here. Can you see it now?
Yeah, slight
Hyper
hyper
intense.
intensity, ma'am.
Yes,
Yeah.
exactly. It's hyper intense. And if you compare it with the other side, you can see, I'm almost regretting that I cannot zoom this image. You can see how beautifully the nerves are visible here. Apart from that, if you look at the image B, you can see that this has come out of the meatus and it is in the cisternal region. This region here is the CP angle cistern. My marking might be slightly off. So the hypointense region here, this is the CP angle cistern, marking the presence of CSF. This is the cisternal component. If you look at image C, you can see that it has reached the brain stem. This is the brain stem, and then it has reached, almost reached. Apart from that, what is going on in D?
It's attached to the brainstem,
Yeah,
but
sort
not
of.
in.
And then what is E doing?
Displacing the brainstem.
If E is displacing, then what is F doing?
Fourth ventricle is compressed.
So E can be classified as compression, right?
Okay, madam.
Let's go back to the table. The Hanover, let me here. So you can see T1 is purely intrameatal, something which was so small that was really, really hard to look at. You would not be able to see it in normal scan unless you're looking at DICOM images, right? It was purely intrameatal, hyperintense signals inside the internal auditory canal. T2 is both intra and extrameatal. You can find it in the cistern, but it's not going to fill the cistern completely, right? You can see it's inside the cistern. Apart from that, let me go back. T3A is when it starts filling the cistern, and T3B is when it starts reaching the brainstem. T1 is purely intrameatal, T2 is intra and extrameatal, T3A is when it fills the cistern, T3B is when it reaches the brainstem, T4A is when it compresses, T4B is when it severely dislocates or displaces, whichever terminology you want to use. Some radiologists might argue that this is also displacing the brainstem, but then again, it is to each radiologist. Apart from this Hanover grading, there is another grading. Which one is that?
Who's grading?
Who's grading? So it was relatively easy. I chose not to include it, but we can discuss it tomorrow. Please let me know if there is something very specific that you want to discuss in this topic.